thank you for allowing us to come. So this talk is going to really be more geared towards vertebral column fractures and more identification and management. For the residents, it was going to be more on the osteoporosis side of things. So I want to gear it up a little since we don't have any residents in here today. So basically, this is a hard X-ray to see. So I'm going to kill the lights for about 10 seconds here. And as we look at this X-ray on the left, this is a patient who fell in the emergency department who had a prior kyphoplasty at L3, and you can see it on the lateral view, you can see it on the AP view. And when you look at the other levels, other than this level, which was noted to be chronic, the rest of those look pretty good. However, this patient was told there was absolutely nothing wrong with him. And although he had a fall, had a prior kyphoplasty, indicative of osteoporosis, and had a lot of back pain. Unfortunately, he was told, hey, there's nothing wrong, so he goes home and he waits 4 more weeks. So he comes back in, he sees us in the office. 4 weeks later, we get another X-ray because he's still having a lot of pain. And when we look at it, we still note that he had his prior kyphoplasty at L3. However, there's some more subtle findings. This guy is pretty well stable from what it was prior, although now we're starting to see some end plate changes here, and we're seeing some end plate changes here over a period of 4 weeks. So what we ended up doing is he had a history of a pacemaker, so we were not able to get an MRI, and I'll talk about that in a little bit. So we ended up getting a bone scan on him, and bone scan imaging showed that it was very hot at 2 levels. For those of you that are not familiar with bone scan imaging, it's a test where you give basically a radionucleotide through an IV to a patient, and for this particular application, it's utilized to look for bone healing or metabolic turnover. So if a person's had a recent fracture, or if they have tumors or things like that that are metabolically active, the bone is hungry, it's turning over bone cells, it will light up. That medication is excreted through the bladder, so no, they do not have a broken bladder. Okay? So we see some metabolic activity at both of those levels that were previously told, hey, nothing's wrong. So the point that I want to make to this is that when you have patients, and I'm going to kill the light again for just a second, thank you, because we put them side by side. This is the initial X-ray in the emergency room. This is the X-ray in our office. And you can see here and here, those vertebral bodies actually look pretty good. And here you can see that there's some superior end plate deformities. So there are patients who will present with back pain, and their index radiographs are going to be negative. However, when you follow those patients, they can actually have fractures and may not be detected on radiographs the first go-round. So sometimes we'll talk to folks and say, hey, you know, if they still got a lot of pain, let's get a follow-up X-ray in a couple of weeks, 10 days, 2 weeks, and look for this, because now all of a sudden this guy has collapsed. Unfortunately, he had to wait 4 weeks before he was seen, and not due to us, but because he just thought, well, there's nothing broke, I got a bruise, I sprained it, and then he eventually came in and was seen. So, you know, the idea is that we want to try to eradicate that time frame and jump on these and treat them more aggressively to decrease the morbidity and mortality associated with these fractures. And I'll talk about that more in a moment. So, what's that? Oh, you like that? The horizontally gifted? That's mine. Yeah, finally, out of all the literature, I'm so tired of being how fat people are the nemesis of everything, except osteoporosis. We're not going to break our bones. So some of the other ones, unfortunately, advanced age, female gender, Caucasian, fall risk, recent fractures, multiple fractures in first-degree relatives, alcohol, tobacco use, menopause, low body weight, and certainly low calcium. I don't know about you guys, but just the short time I walked from downstairs to up here, I think I saw about 98% of that. Except maybe the booze, and I think if I look far enough, there's a Bud Light here somewhere. So, you know, these are very common things that we see every day in the clinic, and these are very common things that we see in rehab type scenarios. People that are breaking hips, sacral insufficiency fractures, humeral fractures. Those patients are the ones that we're talking about here. So the problem is when these folks break something, especially if it's a non-traumatic break or a fragility fracture, 60-some% of those patients go on without any further treatment. And I ask you guys a question when you think about this. If you had a patient that had a heart attack, Would you not treat them preventatively thereafter? Would you not address their cholesterol? Would you not address their aspirin regimens or beta blockers and things like that? And the answer is, of course you would. So why is it that 60–70% of patients that break an arm, break a hip, break a spine, walk out of that hospital, come to a rehab center, and they never get their osteoporosis addressed? They never check the vitamin D. They never check the calcium. They never talk to them about modifiable behavioral risk. The real crux here is when a patient breaks a bone, their increased risk starts going up exponentially, not literal, not linear, exponential. So they break the first one, boom, they're a 5-fold risk for another fracture. If we look at the case study we started with, that patient had a fracture. He was 5 times more likely to break another bone, and they never thought about that. Break 2 bones, welcome to the 12 times more likely. You break 3 or more, you're 75%. You might as well tell them, look, you will break another bone. It's just a matter of time. So the whole idea is we're trying to prevent those breaks from occurring, but if they do occur, then let's try to prevent from further breaks, whether it be a hip, a shoulder, a pubic ringworm bone, whatever the case may be. So how do we find these? This is actually a patient of ours who had horrible COPD, chronic steroid use, and just very kyphotic. And she would call me about every 6–8 months, hey, I broke another one. And she would cry. And it was just a travesty that it went on, and this person ended up having a lot of glue. Fortunately, she got some benefit out of that. So how do you figure it out? Physical exam. And you don't have to be an MD or DO, an orthopedic surgeon, to do this. Listen to your patients. There's the crux. These patients are going to tell you, hey, I don't feel as tall as I used to. I can't stand up as straight. My back hurts all the time. And most of those patients, oh, you're old. Oh, you're just arthritis. I can't tell you how many patients I've treated for spine fractures who were told for months they had arthritis and suffered with it. Because they didn't have back pain a month or 2 ago. Now they got back pain, all of a sudden it's arthritis? Come on, it doesn't fit. Looking at these patients in terms of their overall height, looking for increased kyphosis, that bending over, protuberant belly. One of the other big ones, and I talk to patients about this a lot, is positional change. How do you do getting in and out of bed? Oh, that kills me, honey, I can't do that. Watching them get out of the chair to go get an x-ray. Are they grimacing? Are they using their arms to let themselves down real easily? Or come on in, or get up quickly. Oh, come on in. Come on. You want to learn about this?
Somebody just wants to say hello to you.
Where's she at? Hey, good looking. What do you know?
So good to see you.
You too, sweetheart. How old are you?
I do. Hi, Jeanette.
You doing all right?
Yes, sir.
You gonna stay with me or you gonna go grab something? One of the big ones is the positional changes. Is they really do not like to go from seated to standing or standing to sitting or laying to sitting. That positional change really loads that vertebral body and really hurts them. When they get to a point where they're seated, reclined, or laying and they're getting that body, oh, okay, now I'm better. But if you have me roll over or sit up, oh, no, I don't want to do that because it hurts too much. So positional changes is huge. People that have general diffuse arthritis, that's not their complaints. So there's big differences in those things. So where do we find these? Most fractures, that we see are going to occur between T12L1, which is called the thoracolumbar junction. Why do they occur there? The lumbar spine is very mobile. When you bend and lift and twist, that lumbar spine has a lot of motion taking place. Sitting right on top of it is a thoracic spine. Thoracic spine has the cage, the ribs, so it's a very rigid segment. So you've got this place where you've got really rigid and really mobile meeting, so it's a very big stress zone. Here's a little pearl to throw in your hat. When you're going to order an x-ray, or you're asking, calling the doc to get an x-ray, or the NP, or whomever, and you ask them, hey, you know, Mrs. X has back pain, get T12. Get T12. Because a lot of people get an x-ray in the lumbar spine which stops at L1. Well, what about T12? I can't tell you how many times I've seen patients from the emergency room that come in with x-rays, normal, and they have low back pain. And then you get an x-ray and you open it up and T12 has a fracture. It happens very, very commonly. So when you get x-rays in the lumbar spine, it's not a big deal to say, please include T12, we're worried about a fracture. And it's a very easy thing to do, and you'll cut down on your miss rate substantially. Then the second place is up in that thoracic spine, and it's right at the apex of that kyphosis. And most of the time, I get called to see these is because they get a chest x-ray for something and they go, oh, by the way, they got compression fractures. And some of those patients will think, well, that's just arthritis, it's hurt for a while. And because it's right there at that broad line, that T7, T8 region. So those are kind of the two most common places where you're going to pick them up. Have I had fractures down at L5? Yes. Have I had them higher up? Yes. But when you play the laws of averages, those are the places you're going to be looking for fractures. So how do we work these up? Well, what's the right test? CAT scan. CAT scan's not a bad test because you cannot look at a CAT scan alone in most cases and say, that is a new fracture. And it's very important to distinguish if it's old or new because the treatment's going to be predicated on that. So the other test, which is really the test of choice, is going to be MRI. And I'm going to back up one second before I get to MRI. This is a picture of a CAT scan. So you guys can see they got really good bone detail. And this is obviously a normal vertebral body. And then we've got one here that's fractured. But we don't know, looking at that bone, was that broken last week, last month, 6 months ago, a year ago? I have no way of knowing that. And we'll see a difference in between this and MRI in just a minute. This is a coronal cutter, a picture looking at the patient straight on. And again, we can kind of see the area where that fracture has occurred, where we got a nice normal bone here. So you guys you can see that the CAT scan gives you some phenomenal bone detail, but it just doesn't tell you if that fracture has happened a week ago, a month ago, or 10 years ago. And that's really important when you're trying to work these up. Let's go past that. MRI, so MRI is a little bit tougher now. MRI is a little bit tighter, although most of those little frail gals don't mind that. The big fat guy like myself, we don't like being stuck in these big tubes. They can show bone marrow edema. That's the actual swelling that occurs in the bone when a fracture occurs, and we'll see what that looks like in a minute. If there's any kind of neurologic symptoms, stuff going down the legs, numbness, tingling, weakness, then an MRI is definitely the way to go. One of the downsides is it takes a little longer. It takes about 30, 40 minutes. They're a lot louder. Patients that are very sensitive to sound don't like them. They're very sensitive to motion. So you've got a patient that won't comply and they're flipping and flopping and wanting to get the hell out of the thing. They're not going to do well. You're not going to get good pictures. People with claustrophobia issues, big deal. They don't do well with the magnets. And then lastly is the pacemakers, which is really tough because your clientele has a lot of pacemakers. How many, off the average, how many of your patients have pacemakers right now?
I actually don't have a ton right now on our case.
Well, thanks. And I just blew my talk.
But, it's not
But Dr. Hammer, we have a ton of them.
I'm just kidding, we have a ton.
That's what I thought you said. It's kind of interesting right now, too, because there's actually studies going on to ascertain whether it's safe or not to do MRIs with patients with pacemakers. And there's really starting to be more and more evidence to suggest that that's just nonsense, that patients with pacemakers can have MRIs. Although I will tell you, I would not order it that would put an MRI at this time on a pacemaker patient, not until the literature and the studies are done. The common practices are to not do it. So if they got a pacemaker, consider them non-MRI viable at this time. So when we look at MRIs, do I got one more? Do I got a skirt on there? What's the next one? This is a picture. So this picture, this is an MRI looking at the patient from the side, a sagittal picture. And remember on the CAT scan we saw the fracture, but we didn't know whether it was old or new. So on this patient, there's actually 2 fractures. There's one down here. So you guys see how that lip comes down here? That's a fracture. However, look how dark that bone is. And look how dark that bone is, that bone is, and that bone is. See how they all look alike? So that fracture is old. It's healed, it's done, it's over. It's a broken bone that happened years ago. But what about this little benign, innocuous thing up here? See all that white stuff up there? That white stuff is bone marrow edema, that's swelling. So in this particular patient, if we had an x-ray and we said, well, yeah, there's 2 fractures, but we don't know which is which, you can see how the MRI is very, very beneficial. If we had a CAT scan of that, we would have said, well, there's 2 bones, but we don't know which one's broken and which one's not. So when it's buyer's choice and there's no contraindications, the MR is going to be a lot more helpful in discerning whether one's acute versus one being chronic. And then here's a really good, I wanted to throw this in because then thank you, put some side by side. So you guys can really get the idea of what a CAT scan looks like, how good the bone detail looks, but you don't see anything in the spinal cord versus an MRI where you see the spinal cord and cerebral spinal fluid and disc, and the bone detail is marginal. However, we don't see any bone marrow edema here, but we see bone marrow edema here. So you guys see the difference between MRI and CAT scan as far as its viability with this type of workups. Let's go to the next one. Bone scan imaging we talked about a little bit. One thing I want to caution you guys, and I will tell you, there are primary care docs that don't know what I'm about to tell you. And not because they're silly or they're not inept, it's just they don't do it enough. Bone scan imaging is hugely dependent on time. If a patient has a fall, and let's say they have a fall on a Monday, and you bone scan them on Tuesday, it's negative. It will be negative. Why is it negative? Remember how I talked about they give an injection of a nucleotide that hangs out with the bone cells? Well, when people break bones, especially the older patients, it takes them longer to develop that cascade, that inflammatory response that sends new bone cells to heal. So if you do this and you get a bone scan in the first 24, 48 hours, it's negative. Just give me your $1,000 right now, it's negative, have a nice day. It takes a minimum of 72 hours to get a bone marrow response on bone scan with older patients. So I've had patients that were admitted on a Sunday, got a bone scan on a Monday, and they call me in to see them and say, well, they have back pain, the bone scan's negative. And then come in behind them and I'll give them an MR and say, no, they do have a fracture. So it can happen. It's a minimum of 72 hours from the time of trauma. And that's with the femur, that's with the pelvis, that's with the shoulder, it doesn't matter. So if you're looking for a hip fracture, same rules apply. It's got to be a minimum of 72 hours or it will be negative. Okay? Go past that one. So what do? We figure out, okay, they broke something, what do? Well, some of the treatment options, if you look at the literature, talk about rest. Don't know if that works all well. Oral analgesia, maybe. Miacalcin's a special nasal spray to help. There's some studies that say it helps with back pain. Braces, therapy, or kyphoplasty or super glue. When we look at the treatment guidelines by the American Academy of Orthopedic Surgeons, they kind of go through all of these and they talk about it's inconclusive, maybe helps, and kyphoplasty, they said a weak degree of strength. One of the things about this was their N value, the number of patients they had enrolled, was lower than their acceptance rate, so that's why they did not give it a higher degree of approval. So what do we do about it? Well, these are typical compression fracture patients. These are the ones that are kyphotic and stooped over. We kind of see pictures like this of the older person just getting worse and worse and worse. And, we talk about bracing them, and I always kind of chuckle because this is the company, the brace company gives me this brochure and shows me how cute and nice that brace fits. Can you put that brace on that leg? Hell no. And that's what we see. How many of you guys got this patient downstairs? Right? I mean, come on. So, this just doesn't cut the mustard here. I can tell you because 10 years ago, before we had some of the treatments that we had $1,000 brace, and you guys were the ones calling me going, hey, dumbass, how am I going to put this on this patient? Because it's choking them here or it's gigging them here. So it just doesn't fly. I don't care what the literature says. So, okay, what about conservative treatment? Bed rest. Okay. Well, what happens when they lay in bed and they don't move a lot? And you guys see this. They get weaker. They lose bone density, 2% per week. Muscle strength, 10% per week. Pressure sores increases. Heart rate changes. Decreased coronary flow. Increases of DVT, PE, and certainly the God knows, you guys know better than I do, the fecal impaction and constipation. So all of these are things that get on board when you treat them conservatively. So the idea is you want to try to get these patients moving and getting them going, trying to get rid of their pain, because what's keeping them down? Pain. One of the questions I ask a lot of the patients and their families, which is huge, is how was mom or dad prior to the fall or prior to the break? Oh, dad would walk, dad would golf, mom would this, mom would that. Could you do that now? Oh no. Why not? My back. So when you get those kind of scenarios, those are patients who will do very, very well with some operative intervention, sometimes like the kyphoplasties or vertebroplasties and things like that. One of the other things that's always concerning is some of the old school guys will say, well, let's just watch it. You got an old lady fracture. We're going to watch it. Well, here's what watching it gets. March, April, May. Easy, 30-minute procedure, little to no risk. Much more concerning, paralyzed, big bone. That's what watching it gets. Does that mean everyone turns into this? Absolutely not. But have I seen this happen? You betcha. And the problem is I don't get called here. Sometimes I get called here. This is when they call and say, oh, you got a problem. What? Hello? Next. So this is I threw this in here because it's kind of an interesting case. You're my light, Lynn. You're my savior today. So when we look at this, what do you guys think? You think there's a fracture in here or not? What do you think? How about that? So we look at it, this is a 92-year-old patient who wouldn't get up and walk because she had severe back pain, had imaging, and clearly has a compression fracture. Let's leave the lights down for a minute if that's okay with you guys. And so we talked to this lady. We talk about risk benefits, and one of the nicer things about putting glue in patients or kyphoplasties and things like that is the relief is almost immediate. And I hate using that word, but when I say that, many things in surgery take weeks, months, if not longer, to get better. But people that have kyphoplasties, vertebroplasties, cement augmentation, whatever term you want to use, in the appropriate applications, which is the big key here, those patients do a lot better. They get moving better. They're outpatient types cases, and you can really alleviate a lot of their discomfort. Go ahead. Very, very well. And I wanted to throw just a quick couple of pictures in here because I don't know how, are any of you guys familiar with kyphoplasty or cement or any of that? So a couple of you are. So I want to show you guys how easy this is. So the patient, you give them a little light sedation, you put some Novocaine in their back, and then basically these things are called pedicles. And you put a needle down into the pedicle, and you get this nice fill of cement all through that vertebral body, which gives that fracture cleft support. And that cement gets hard in about 7 or 8 to 10 minutes. It's rock solid. It's done. It's over with. So you can see kind of what it looks like on a CAT scan. You got this nice fill. This patient has substantial reduction in pain, and they're able to get up, get moving. And let's go back one. That's okay. And they get up, they get moving, they're able to participate in therapy, which keeps your caseworkers happy and it keeps Medicare happy. So one of the things that I like this slide is people that miss these, that don't treat them or don't pick them up. It's not just back pain. It goes to deformity, the kyphosis. Then you get kyphosis, you get decreased lung capacity. Because if that patient's like this, their lungs are being shoved, their belly's being shoved up into the thoracic cage. So there's some studies that suggest that FEV1, the volume that you can inspire and expire, decreases by 10% per fracture level. So you start talking about 2 or 3 levels being broken, you just rob them 30% of their capacity to breathe. impaired function, loss of appetite, decreased activity, and then it's a long spiral until eventually they just succumb to death and they don't do well. So there's a lot of morbidity and mortality associated with this. I'm not going to go read through all these because it's basically surmised on that previous slide is if you find them early, you can avoid a lot of all this nonsense and they'll do a lot better long term. You can blow through those. So basically it affects a lot of the population, very common due to obviously osteoporosis, steroids, cancer. You can also get other deleterious effects, robbing them of their independence. And again, kind of that whole downward spiral. I want to be independent, I want to be at home. You guys hear these songs every day. So these are the kind of things that trying to identify those fractures early so that they don't lead to new problems and worsening symptoms is kind of where we're going. You know, there are some non-surgical things. I'm not going to tell you every person needs glue in their back. That is absolutely not true. I have patients that, hey, they're getting better, I'll brace them, but I'll watch them closely to make sure they don't collapse, like maybe take an x-ray every couple of weeks and tell them, hey, if it collapses, we may have to do something. You know, you correlate it a lot with their pain, making sure their neurologic exam's okay, which is, those are my problems. But really just identifying them is the key and then getting them to the appropriate referral source to take care of them. We can go to the next one. I gave this talk before out of town, so I wanted to show that it was hot. So it was a St. Louis snowy day with the orange, of course. Alright, sorry if I blew through that. I didn't want to take all your guys' time. So, do you have any questions, concerns, thoughts, comments?
What about the rods? Is that a common thing as well too? Put rods in?
You try to avoid, there are surgeries where if the person had the, like when I had the 3 in a row, the one on the very far right, that would require that type of procedure because what happens is you have to go in and decompress the spinal cord, take the pressure off, and by decompressing it, you then have to stabilize it, and in that application, you would absolutely have to put percutaneous screws and rods in there. And that is a substantially big surgery compared to 30 minutes of a little glue and a small little nick in the back.
And that's probably not so much as for osteoporosis, or more,
Well, which thing, I'm sorry?
or just more like a severe back.
It would be for a burst, they call it a burst fracture. And I've seen osteoporotic burst fractures, absolutely. And more times than not, some of them are caused by docs and people who don't know what they're doing. I'll give you a good example. They have back pain like we saw in the very first image. They never x-ray them, and they're in the category of a patient that's high risk, and they send them to therapy. What's the first thing therapy's going to do? Oh, we're going to weight-bearing exercises, bend and lift and twist. And all of a sudden, they come to us and they're like, I'm wetting myself and I can't feel anything. I get an x-ray and they got this blowout fracture and their spinal cord's compressed. And it's like, man, I mean, and I look back and go, man, compression fracture. You know, now all of a sudden you got unable to walk and a incontinent patient who has to try to self-calf. I mean, you're talking some really bad morbidity here.
There was a bullet point on your second to last slide, something about
Can you reverse it?
compromising like the pulmonary something.
Yes.
Here, increased mortality. But so is there a direct correlation then between osteoporosis and someone who has COPD or?
No, I wouldn't say there's a direct correlation. What I would say is a direct correlation is compression fractures in the thoracic spine. Mm-hmm. As they compress down, you have increasing kyphosis. As you increase the kyphosis, your ability to expand your lungs decreases, and that FEV1, functional expiratory volume, FEV1, is purportedly 10% per level is a ballpark number. And they measure that by doing, obviously, spirometry type exams on those patients. So,
Is a procedure with the cement covered by insurance?
Medicare is the easiest one to get it with.
Okay.
Yeah. Some of the privates are a little bit harder, but this is a case where Medicare doesn't fight you on it. It's wonderful because you call them up and we've literally been able to do them in a 24-hour turnaround where a patient comes in, I see them, hey, you got a fracture, we've had it worked up, call Medicare, Medicare is great, fix them up, wonderful, and be able to put the glue in them and actually have them come in, get the glue, and then go out to dinner that night if they want. It's really impressive how well those patients do. Can I tell you, everybody gets that? Absolutely not. But the right candidate, and that's what's important. If you got a patient who's squished to 95%, that's not the right candidate. If you got a candidate who had a fracture and it's old, that's why we get the MRIs, not the right patient. And I explain it to people like that. I said, look, I need the MRI to know, is this going to help you? Because my goal isn't to see how many people you put glue in, it's to make your back better. And if I get an MRI and it's not positive, there's no bone marrow edema, I explain it like this: if you broke your arm a year ago and I put a cast on it today, it's not going to do a bit of good for you. So you try to, and I've had those kind of cases where I thought, oh yeah, it's a fracture. Get the MRI, and it's not. It's not an acute fracture, it's an old fracture.
This is just a little off subject, but related to when you said, if you fracture this, you're twice as likely to fracture this, 12 times. Are you saying that with people that have like balloon discs and herniated discs, to after they get a laminectomy or discectomy?
Has apples and kiwi. No correlation whatsoever.
But the disc, so when they get that laminectomy or discectomy, it's not weakening the other side?
No,
Yeah,
well, it depends because those are two different operations. But if you do a discectomy, usually it's a unilateral procedure. So the contralateral side, you don't strip all that muscle on the contralateral side. You don't take the facet down. You don't take the lamina down. On the affected side, you try to do what they call kevolaminectomy or laminotomy, which is very small, and you're only reflecting a little bit of that muscle. So I wouldn't say that, oh, if you do a laminectomy at 4-5, you're going to blow the disc at 3-4. I wouldn't say if you have a laminectomy at 3-4 on the right, you're going to have a laminectomy at 3-4 on the left.
that's a common misconception, I believe, right?
I agree with that. The one thing that I think holds some kernel of truth, which is dovetails on that comment, is that with fusion surgery, you fuse one level, you take 4-5, you make it rock solid. The guy next door is going to work harder, and it can lead to advanced, we call it ASD, adjacent segment disease. I would absolutely agree with that.
Yeah.
There are things you can do to mitigate against it, besides operating on those people. I mean, tell them, look, core program, weight loss, the surgical approach can make a difference, whether you go posterior versus anterior or lateral versus anterior. Depends on how much collateral damage you do to the surrounding tissues. All of those things could predicate on whether that patient's going to have a proclivity to have adjacent segment disease or not. So, a lot of variables there. Because what's really frustrating for us is take you guys and you all get an anterior fusion, and 3 of you get adjacent segment disease and 3 of you don't, and you all did pretty well the same thing. And you just don't get it. You don't understand. Why does it happen with this guy but not this person? There's not one common denominator to all of those things. So. Yes, ma'am. Ladies first, sorry.
What are your thoughts on Fosamax and other drugs that are prescribed for treating osteoporosis?
Great question. Wonderful question. So the first way I'll answer it is I think it's great that somebody at least paid attention enough to put them on it. Second thing I would answer is I think they have to look at what is their bone mineral, what's their DEXA score, what is their risk factors, and have they had any non-traumatic fractures? And then based on that, are they being undertreated? And I think a lot of times they're being undertreated. Or they have a fracture, they're put on medication, and then they break something again. Those patients should unequivocally have change in therapy. They should not be on bisphosphate, they need to be bumped up. And usually, and I've had those, I usually will bump them to either Prolia or Forteo if I can cover it. So that's a real travesty when people their T-scores are -3, -3.5, they break a wrist, then they break a back, they break a hip. Hell, they're on Fosamax. That don't cut it. The other problem is a lot of those patients aren't having their vitamin D looked at, so they're hypovitaminosis D. So they can take all this stuff they want, but if they don't have any calcium and vitamin D to synthesize with it, not doing much good. So I think providers reflexively just have put you on bisphosphonate, take it once a week, everything's good. Not always, not always. So some of those patients absolutely need a change in therapy. Yeah.
If you just decide you want to do a kyphoplasty, what's your ideal timing for that? I mean, I'm sure there's too early, too late.
Yeah, typically, I think anywhere between 2 to 4 weeks is very reasonable. You always like to try to give some hygienists a cool down, is what I call it, and see, because I've had patients that'll come back in a couple weeks and go, I'm doing a lot better, I'm moving better, I'm not having as much pain, and those people, I'll tell them, look, we can watch this, we can treat this conservatively.
Two things. We sent somebody for a kyphoplasty yesterday, just to support your statement. She came back, she left at 6:45. I think she was back by 10:30 or so. She attended her care plan and she was pain-free in that part of her body.
Does she have a left tibial plateau fracture?
Yeah.
She's mine.
Yeah.
Sweet thing too, I love her to death. She's great.
She is so sweet.
She is,
She
she's
really,
great.
her knee hurts from running down, but
Yeah.
her back pain.
And that's a great argument. I mean, this is a lady who fell and broke her tibial plateau, and she broke one of her vertebral bodies. So she gets a procedure done over at our office, takes 45 minutes to an hour. Her back pain's better. Clearly, she has a broken leg that still hurts. So, this isn't a sham. I mean, this stuff works, and people get better with it. And now, if it wasn't for her knee, she'd be up walking and participating in therapy. But the knee's going to prevent her from being able to do any weight bearing. Thanks for the update, though. I appreciate it.
Sure. And the other question I